Good evening. Welcome, everyone. Happy New Year. We appreciate you joining us for our very first webinar, kicking off 2026. We're very happy that you're spending your evening with us. My name is Lauren Lefebvre. I'm one of the product managers here at Trees Medical. And once again, thank you for joining us. We do one of these every single month throughout the year, sometimes two. And we really enjoy hosting these programs and having you all attend. If this is, however, the first time that you are joining one of our webinars, a few logistics and housekeeping items. Upon joining, all attendees are automatically placed upon mute. However, as mentioned, we really like for these to be interactive. So there is a panel to the right-hand side of your screen with a questions tab. Please feel free at any point throughout the event to type in any questions or comments, and we will monitor those as we go. And anything that we don't hit on during the event, we will have time at the end for any remaining or additional questions and comments as well. So without further ado, I would like to introduce our esteemed faculty for this evening. We're excited for this particular talk with Dr. Will DeCarbo out of Pittsburgh, Pennsylvania, and Dr. Jude Violante out of Buffalo, New York. Please send your condolences to him for the very tragic Bill's loss this weekend. But both of these surgeons, we launched Speed MTP right at the very beginning of 2025. So we're about a year in, and both of these gentlemen have over a year's worth of experience with the system and with the implant. So we're really excited to hear their experience and what they've seen over the last year. So gentlemen, welcome. Thank you so much for being here. And Dr. DeCarbo, I will turn it over to you.
Well, thanks, Lauren. Jude, we spoke about the loss. We're sorry to hear that. You know, I see Darren Bergman on this call from New England, and if they happen to win, they didn't beat Patrick Mahomes, they didn't beat Buffalo and your quarterback, so you know there'll be an asterisk by that. So
there should be an asterisk there for sure.
Just so you know, Bergman. Anyway, Jude, I appreciate you being here. Everybody on the call, we're going to go through Speed MTP, and it's one of our newest iterations at Trees for a problem that is very common that we have at the first metatarsophalangeal joint. We are paid consultants in order to do this. So the agenda is just going to go through some of these bullet points, and we're hoping to really spark discussion. As Lauren said, there'll be a question button at any time. Ask questions, and we'll do our very best to answer them. Trees is really a family of procedures and a philosophy. You know, we've been doing this now 10 years, and it's really a philosophical approach to midfoot, forefoot, hindfoot deformity. And we feel like we have best in class fixation, and the Speed MTP just kind of triggers us into that new fixation option for this anatomic option. When you have a patient that comes in with a bunion, they either have arthritis of the first MTP or they don't. And this algorithm goes through the path of they have arthritis of the big toe joint, and you know, what do you do? So Jude, patient comes in, everything around the big toe that hurts or is a bump is a bunion. So they come in and they have arthritis of that big toe. You know, what are the patient perceptions? How do you handle it? What do you tell them at this point? They don't expect this. They think they just have a bunion.
Well, you know, of course, first and foremost, you know, we go over the x-rays with the patient, you know, demonstrate, you know, that they do have, you know, a certain amount of arthritis within the joint. And I try to make it brutally clear that if we do just a straight Lapiplasty, you know, they're only going to be partially happy with the results, because they are going to continue to have, you know, pain and discomfort, soreness, which will just get worse over time. And that's usually when I start a discussion about, listen, I think the best option for you is to consider a fusion here. And you know, they are generally really perceptive to it. I
Yeah,
present
that's
it.
actually a really good point. When that joint is offloaded, sometimes, radiographically, clinically, they'll have hallux limitus, radiographically arthritis, and they'll be like, well, it doesn't hurt that bad. But once you realign that unloaded area of the bone, to your point, that progresses. And then,
Yes.
they're subject for a potential second surgery, down the line.
For sure, for sure. And it's almost when you open up the joint, it sometimes seems as if that even accelerates it too.
Yeah, no, what a great point. How do you debunk kind of the stigma, the second bullying point, where people are like, well, I can't not have motion of the big toe. How am I going to walk? What's going to happen? How do you kind of address that?
I try to tell them that you'll be able to do everything you want to do. The one limitation is usually for women or females in regards to the style of shoe that they may want to wear in the future. And I'll tell them there's only a certain height of a heel that you'd be able to wear, and so on and so forth. And most of them just kind of laugh at me and say, well, I don't wear heels anymore anyways.
What's the height that you quote them, Jude?
Yeah. But I try to tell them that we've been doing this for years, and I don't know if I've had anyone come back to me and say, you know what, I'm upset that I had my toe fused, and this is the worst thing I ever did, or I've never dealt with anything like that. So it's just more proof that it works. And I also demonstrate that they can, they gain their motion at the interphalangeal joint, and they're always just been very receptive to it.
Yeah, I think that's a good point that we'll bring up later about the IPJ joint motion and fusion. The other thing, Jude, that I do is I load their foot and try to dorsiflex their first metatarsophalangeal joint. A lot of these patients have such hallux limitus and rigidus, they don't have motion now and just the pain. So I tell them your foot will function the exact same, just without the pain.
Yeah, that's a very good point, and you are correct, because I do the same thing as well, and just clearly demonstrate, like, look, your toe doesn't move that much to begin with, so the only thing that's going to be better is you're not going to have pain afterwards. So very good point.
Yeah, a couple of studies, one by Mindy Dayton et al. And the other by DeCarbo about return to sports, and these both come out about function of the big toe joint. And when we look at different options for arthritis, whether it be decompression, arthroplasty, or implant or whatnot, the fusion is still the gold standard. When you look through the literature, it's a B recommendation, and there is no A recommendation for first MTP. And basically this talks about getting back to sport. The DeCarbo study I quote all the time. Jude, this is 22 different sports with return at 96% satisfaction after 6 months. Do you talk to patients in regards to literature or function in this regard?
I generally don't try to quote literature, just partially in fear of misquoting it or telling them something inaccurate. I just say usually more in generalized terms that a lot of the research has shown that upwards of 90+% of the patients have been able to return to almost every activity that they were doing before.
Yeah, no, it's a great point. And I'll try to say something like that: run, jump, basketball, football, soccer, rugby, whatever you want. And that really resonates with patients. So, a lot of times they don't have that motion. It's a pathological joint. You're just stabilizing it and taking the pain away. Before, whether it be Treese with biplanar plating or first MTP, what was your typical construct for first MTP? And then what was your takedown of the joint?
My typical construct was just a single dorsal plate. And when you say takedown of the joint, what are you referring to, Will?
So the top picture, cup and comb reamer, or you could do wedge cuts, like flat cuts.
Yeah, no, I would almost always do the cup and comb reamers. If I was going in to do a revision, I would more or less do flat cuts because I would be putting a block of tricortical bone crest in there, and it's just easier to fit, straight cuts in there. But yeah, that's when I take it down the cup and cone, and then of course you're going to do your reaming of the metatarsal and the phalanx. You'll do your drilling, and then I like to take a small sagittal blade, and sometimes I'll put some additional, almost like a crosshatch cut in the metatarsal head and in the base of the proximal phalanx. Just another layer of insurance, along with bone grafting that clearly we want to try to do everything possible to make this heal, because we don't want to have to come back and do a revision.
Yeah, and we'll get into augmentation, bone grafting, and whatnot. When Treese had the biplanar plating, did you ever dabble in the biplanar plating with the first MTP fusion?
I did, sometimes it was difficult to find some real estate in the area to put the two plates. Sometimes I just didn't really love the way they sat. There was I believe, Will, correct me if I'm wrong, but is it the S4 plate, which is bent distally? Sometime.
Yes, the S4A is the one you're seeing all the way to the left.
There you go. Yes, yeah. I don't know. I felt like there was times where I was struggling with trying to make it look. Sometimes I think we struggle to make it look X-ray pretty, but in reality, it's totally fine. So sometimes I struggled with a little bit of that. Ultimately, they ended up working out fine. So that was my experience with the biplanar plating.
Yeah, and the reason we say this is because the biplanar plating users, this is extremely successful, extremely viable option. It's just the majority of patients use a dorsal plate, and we'll kind of talk about that. So, internal and external studies kind of showed that dorsal locking plate with interfrag screw was the most by far common construct. So, we wanted to try to meet the market, so to speak, on a functional plate that accomplished this. Any problems with previous plates, as far as being bulky or this sort of thing? Without saying a brand name, like did you have issues?
I think one of the biggest issues is the one plate that I used a lot of. I feel like looking back on it, I had to go back 6 months to a year later and take that hardware out on quite a few of them, whether that was from soft tissue irritation or just some sort of reaction to the plate. So I did deal with that. When you're dealing with some of the older plates, I just felt like you lost the ability to put the toe where I felt was the best place for the toe, and the plate in essence kind of just put it where the plate wanted to hold the toe, and I didn't always love that. So
they were pre-contoured. Yeah, some of the pre-contoured plates were certainly problematic. So a couple of the things in regards to this was the plates were bulky, had a potential for a malunion, just as Jude's saying. If you have a pre-contoured plate, it potentially could drive the correction, and there's no dynamic compression within the plate. One of the things with the biplanar plating with Treese that we started at the TMT and then extrapolated to the MTP was joint visualization. Now, some people say, well, I hope I don't see the joint, but we wanted to see the healing, show the patient the healing. So we wanted visibility with this. The outcomes on first MTP fusion are high. Most are immediate protected weight bearing. And we wanted something that obviously did that, and that's compatible with hallux rigidus and hallux valgus surgery, and also have the interfrag screw. We'll dig a little deeper, but do you throw the interfrag screw on this, Jude?
Yes, yeah, I do every single time.
Okay, yeah, and we'll talk about it. So what that did was the iteration of our system is now what we call the Speed MTP. and it is a continuous compression plate. So this kind of dovetail and springboards off of speed plates. So Jude, did you use speed plates at the TMT and lesser TMTs previous to this plate coming out?
Yes.
Yeah, and so really that continuous compression, that stability, that ease of implantation and quickness, so to speak, efficiency is really what happened with this. And in addition to it, we added bicortical off-axis screws. And, you know, I really think that is the difference of this plate besides the continuous compression. It's that off-axis screw to give stability with this. You have any thoughts on the Speed MTP with the addition of those off-axis bicortical locking screws versus just the standard speed plate?
The engineering is incredible. I love the fact that the compression, you get the compression in the middle of the plate, and it provides that continuous compression. And the targeting guide for the lag screw, for the first couple of times I kind of said, you know what, I don't need to use it. I can throw the lag screw myself. And then the first time I used it, I was like, wow, this is actually pretty cool.
Yeah, what a great point. You know, surgeons are skilled and they certainly can do all this and freehand it, just like you're saying. But when you have a system that allows you just a consistency and an efficiency, it makes perfect sense to do it. And we'll show this targeting guide being used in the upcoming slides. So the plate, to my knowledge, is the thinnest on the market. It's 1.3 millimeters in thickness and kind of has a rounded edges. We call it Porsche-fied. And to your point, Jude, the design was to try to stop any soft tissue irritation, specifically with the soft tissue, the extensor tendon over top, causing any issues. Those off-axis bicortical screws go at a 25-degree angle, and it just adds an out-of-plane fixation. We find that tremendously helpful with the overall stability as well as the interface between the bone and the plate. What is interesting is it comes in a standard and a large, and the standard is 40 and the large is 45, and it's a 0-degree angle. And most recently, we added a 5-degree angle for a lot of the surgeons that want that dorsiflexion into the plate. And that's something we'll talk about with positioning. Now, Jude, do you have any thoughts on a standard 40 millimeter versus 45? Is there a time where you use the 40, a certain patient that you use the 40 on versus the 45? How do you choose between the two?
I think you could just make some intraoperative decisions. I think it's kind of, if you have, a patient that 6'5", 300 pounds, for example, he's going to have a larger area, and I think the larger plate would certainly be a better choice there, because you do want to make sure that you have enough of that, hardware foot plate in there. Yeah, and interestingly enough, I think maybe only once I've had to use the large plate. The standard plate has been my workhorse so far, for sure.
I think it's a great point. One of the things in my practice, so I'm getting choked up here. One of the things in my practice is if you have maybe a size 8, size 7 foot or lower, it's usually the standard.
Okay.
If you're pushing a size 10 or higher, I tend to push towards the large. Some of the male patients, tend to have a bigger foot just structurally. And so I'll push to the large on that. But it's really surgeon preference. The way this is set up is, try to go to the next slide. The way this is set up is this is the kit. And in the kit, if you see in the top right, the standard and the large guide come in the kit. So you do not have to make that decision preoperatively. This can be done purely intraoperatively. And
I was just going to say that, Will.
Yeah, go ahead.
You can measure with drill guides. Once you get everything all prepped, then you can just decide right then and there which one you think fits better. So that's another easy way to do it.
Yeah, so that's a really unique feature because you're not buying into the larger standard. You can literally try it on the patient, see what fits the best before the implant itself is actually open. So what comes in this kit is the cup and comb reamers, the guides for the large and the standard as noted, the SureFire interfrag screw, and then the driver and all the equipment to put the screws in. One of the things that's very interesting, and we'll show videos of this a little later, every procedure and philosophy that Treece has developed, we've tried to do accompanying instrumentation to make it easier. And two of the things on the Speed MTP are the great release and then the feather rasp. And the great release is for a circumferential joint release, and feather rasp is bony contours. We'll talk about both further in a minute. But Jude, how do you feel about these products? Anything to add in regards? Have you tried these?
Oh, I absolutely love them. I love the great release because I'm sure everyone that's listening right now, when you go to grab the set of McLamry elevators that comes in your standard podiatry tray, they're never sharp. And, I feel like I'm always potentially doing more damage trying to use that instrument, where the great release is super sharp, super sleek, and it does a great job. And I can't say enough good about the feather rasp. I absolutely love it. I've used it for all kinds of different procedures. It's such a neat little tool to have.
100%, and we'll get into that. What's interesting to note about this system is this is the tray, and then when you open either the standard or the large, the plates or the screws for the plate are as noted. They go from 12 to 20 millimeters, and you pick which length you want. And then the interfrag screw, it's a 3.5 headless, comes at 26, 30, and 34. So you get that set opened up. You choose the screw that you want to use, and we'll demonstrate this for you. So, really, we wanted efficiency. We wanted continuous compression, low profile. We wanted to see the joint. The biplanar plating allowed us to see the fusion site and the trabeculation of bone. We wanted to continue that. A flush, fit to the bone, so to speak, an ability to position the toe wherever you wanted it. And, we'll kind of talk about that. But, early thoughts on this, Jude. This has been out about a year now, where we have patients. Your experience with it from a standpoint of post-op patients' experience with it. What are you hearing and seeing in your practice?
It's great. I mean, it's just I don't have enough good to say about it. I haven't, knock on wood, run into any issues with it. It's an easy system to use. It's low profile. I love the fast pitch screws, because once you flatten everything out and then you do put the plate in, if there is even just a tiny little gapping between the plate and the bone, those fast pitch screws, will minimize that even further. It's just it's a great system. I just, I haven't had any issues with it to date. And, there's some different little, things that everyone will do when they're doing the entire procedure. And I feel like I've started doing things one way, and then I've kind of evolved into doing them what I feel is a better way. And everyone, I think, will sort of figure out their little, different steps and little changes in the techniques. But yeah, it's been fantastic so far.
Yeah, and this picture shows it very well. We're going to go through the technique here in just a second, but this picture shows it very well, where the off-axis bicortical locking screws that go through the plate are shown medial. This plate can be flipped if you feel it fits better the other way, and those plates can be coming from, or those screws, I'm sorry, could be coming from lateral. Yep. So you could put this on any way you want. It's just super user friendly, for this, and we'll show that in the demonstration. A couple of things that we try to continue to profess: single layer dissection. We don't want any spreading or ripping of tissue. All sharp dissection, subperiosteal. The cup and comb reamer are really important to get the calcified cartilage off. It's not enough just to get down the cartilage. You got to get through that subchondral bone. Jude, you had a great tip where you do the saw and you kind of crosshatch that, huh?
Yeah, it just adds a different layer. If I feel like the bone is really hard, or if everyone's may or may not have some experience with the reamers. You got to be really careful with those because those can chew through the bone rather quickly. And if I feel like I'm really kind of pushing on it, and I'm feeling a lot of resistance, and I think I've gotten enough of the subchondral plate off, then I'll maybe add some additional cuts with the bone saw just to add to the bleeding within the joint, which therefore is going to add to the overall healing there.
Yeah, so like everything, the cup and comb reamers with trees are efficient. So to Jude's point, you kind of have to pulsate that, to make sure you're getting down through the subchondral bone in a controlled manner. The great release allows complete release. It's important to release the collateral ligaments as well as the sesamoid complex, especially with patients that have concomitant hallux valgus, really to realign that.
Yeah. That's been excellent. It very easily and very efficiently does what it's intended to do.
And then the fibular sesamoid removal, a lot of cases where there's hallux valgus, I take this out routinely at this point. I feel like that completely decompresses that lateral soft tissue and allows me to put that first metatarsal and metatarsophalangeal joint in alignment easier. Is this something you've tried?
Absolutely. Yep, for sure.
Yeah, and then we'll talk about position and contouring of the bone and whatnot. So each of the systems that we have with Treece, we try to break down to 3, 4, 5 steps. And, we're going to joint prep. We have the cup and comb reamers, as we said. We have the alignment and the positioning, the interfrag guide. We're going to implant the actual plate, the Speed MTP implant, and then energize it and release the cap. And we'll kind of show that process, through the subsequent slides. I want to show the joint
Dr. DeCarbo, before you go
Yes.
too much farther, there was a question that came in, kind of going back to the tips for consistent correction and fusion. What do you do if hallux interphalangeus is present or prominent?
Yeah. Jude, you want to handle that? Hallux interphalangeus is present with arthritis at the toe. What do you do to try to correct that?
Well, I think there's definitely this is a problem that can be difficult to deal with. I've had discussions with some of my colleagues about this, and I think doing an arthroplasty at the interphalangeal joint is certainly maybe one of your better options.
Yeah, so to your point, it's a tough thing because if the arthritis and the angulation is egregious enough, sometimes you confuse both. Have you ever done any sort of corrective osteotomy at the distal portion of the proximal phalanx and then still fuse the first MTP?
No, I've thought about it, but if there is a little bit of hallux interphalangeal deformity, then what I'll try to do is ream the base of the proximal phalanx in a way that kind of helps to correct for that. Instead of putting the pin centrally, I'll sort of angle it, so I'll maybe take down a little bit more of the medial part of the proximal phalanx, and of course when you bring it together, then it kind of helps to take some of that interphalangeal deformity out of it.
Yeah, so you're really just trying to pull the first and second toe apart, so the first toe off. And so
Right.
the beauty of a first MTP fusion is you don't have to be line to line, so to speak, on the cup and comb, per se. You can put this in a little bit of varus because you're fusing it, and it's not going to tip because it's fused. And so that's a great point, and that's probably how most of the time that I would handle that as well, just to pull them off. Kind of rare to do a double fusion, IPJ and MPJ.
I think I've done it once in one very unique situation, and I do believe that this is probably 5 to 8 years ago, and she ultimately did fine with it. But Yeah, no, there's usually not enough real estate to try to do a little corrective osteotomy there. Then how do you fixate that? Then you have the plate there. It's just there's not enough room to do anything like that.
Yeah. Have you ever done an arthroplasty of that IPJ?
I
If
have.
it's bad, yeah, the same. So if it's bad enough, use the MTP, take off, 3-4 millimeters of that head of the phalanx and, just let it kind of scar in over time. And that seems to solve the problem.
Yep.
So Jude, this is the great release, and this is releasing. You want to talk through this and what's your thoughts on this technique and this instrument?
Yeah, it's you're just exposing the joint there, and just kind of like you're using a McLamry like we've always used. You use it the same way, and you put it directly into the joint, and then you kind of move it medially and laterally, just so you get a really good free up of that sesamoid complex. And because if you have some tight soft tissues in the joint that you missed, you're going to have a little bit more of a difficult time getting a full exposure. And so I think it's definitely a crucial part of the procedure for sure.
Yeah, and just like we talked about, whether it be the speed release, the tritome, and this kind of has like a tritome tip on it, whether we talk about lapitome or razor tome, the idea is, do we have a single-use instrument that will perform each time, sharp, do what it's supposed to do, and move on. And so we've tried to augment these procedures with this equipment. And after the next slide, we'll get into feather rasp, which is just fantastic. But the next slide is positioning, and positioning for any fusion is king, and no different at first MTP. So, a couple of options here. One is an intermedullary wire and then an off-axis screw, and the other's two crossing wires to hold this. Jude, how do you temporarily fixate this? And we'll show a video at the end here, but what is your technique to align this, and how do you align it?
So prior to lining it up, every one of these cases I always do a fast grafter. So we'll take the calcaneal graft, pack that within the fusion site. Originally I would hold the toe, and just more or less eyeball where I thought it needed to go. And then I would, hand throw the K-wire from the medial portion of the proximal phalanx across the joint and come out laterally, proximally and laterally. And then I would, take an X-ray. If I didn't like it, I'd pull it out and maybe like readjust it. But I felt that I was running into trouble with that. So what I do now is you put your K-wire down the metatarsal, ream it, and then you do a double-ended K-wire, and then we'll bring that all the way out through the proximal phalanx out of the distal portion of the toe. And it's much easier to handle the toe and position the toe with that construct. Once I finally get it where I like it, then I'll drive that K-wire in just a little bit. I'll take an X-ray. We'll do our test, which we'll talk about here in a minute, with the tray top. And if everything looks good, then I'll deepen that K-wire. Because sometimes if you put the K-wire all the way in, it may have a tendency to want to follow that same path. So that's why I put it in just a little bit before and check the position and make sure I'm happy with everything.
Yeah, so no different than a lesser toe arthroplasty if you're using a K-wire for a hammer toe. So you're going to kind of antegrade the wire out the hallux and then retrograde it back in the proximal phalanx. I do the same. I find that tremendously controllable and producible, because your one hand is controlling the toe through the wire, and the other hand is mimicking loading the foot in order to get your simulated weight bearing and cross the wire. Then at that point, you can leave it in to two cross wires. We'll kind of talk about that. So once it's positioned, I'm going to play this video. There's a flat plate, and then you have, any sort of device. This is a freer. And what are you looking for as far as alignment on the sagittal plane?
Typically, what we're looking for is there's a little bit of space underneath the proximal phalanx. So you should be able to put, typically we'll use the end of the forceps, and that should go underneath there without any resistance, and then drag it out distally, and it should just have just the slightest amount of resistance at the really it would be the plantar surface of the distal phalanx, and if it meets both of those criteria, then that's what we've used to deem it to be an acceptable position.
Yeah, so great point. This is a very important step in the surgery, because there's two things that patients don't like, in my opinion. They don't like the toe not purchasing the ground. That's probably the biggest complaint that I see from revision surgery, where the toe doesn't touch the ground. And then to the other point that Jude made earlier that I thought was substantial, was the IPJ joint motion. If preoperatively the IPJ joint has pretty good dorsiflexion, and then typically what I do is I'll load this, just as you're saying, it's almost dorsal cortices as neutral or dorsal cortices 0. So when you load the foot, you can't get the freer or the instrument underneath the first metatarsal, but it easily slides underneath the pulp of the toe. If that IPJ joint is stiff preoperatively and you can't dorsiflex it in a closed kinetic chain, then you may want to think about, putting that hallux at maybe a 5-degree, dorsiflex position to the first metatarsal head. So just something to think about. That's kind of how I see it, because ultimately you want them to propulse heel to toe off that medial column. And there's problems if it's too plantar flexed, and there's problems if it's too dorsiflexed.
Correct. Yeah. No, those are all very good points. And interestingly enough, when you have a patient with an arthritic joint, it always seems to surprise me at how mobile, more often than not, that interphalangeal joint is, and it's almost like it's adapted over time to the loss of motion at the MTP.
Yeah, no, good point. That brings us to the feather rasp, which is probably the greatest instrument that has ever been invented. To Jude's point earlier, I use this almost in every application of foot and ankle surgery where there's a bony prominence that has to be taken down. This thing's just phenomenal. So just to give a quick background, the Speed MTP is no different than the Speed plates. So once you put the guide crossing the bone segment that you're going to stabilize, the guide has to sit flush. There can't be any teetering. And if there's any teetering, the bone has to be removed underneath the guide. The guide mimics the plate. So the plates can't be bent. They can't be contoured. They can't be bent. So you have to do that with the bone. And what the feather rasp does is it fits onto your drill handle, and it literally is just like a power rasp, and it's absolutely phenomenal, super quick on and off. And then you plane down that bone and then allow the guide, hence the bottom of the plate, to sit flush. What do you have to add on that, Jude?
Yeah, a lot of times there will be a rather large dorsal bone spur. So when we're prepping the joint, we'll use a sagittal saw and try to recontour, take the bulk of that off. And then once we're at this step where we're putting the drill guide on, then we'll pull out the feather rasp and make sure it's all nice and smooth and no teetering. And it just does such a great job.
Yeah, and one of the best parts about this is once that fixation is all in, where we're not there yet, once we have the interfrag screw and the Speed MTP plate implanted, any bony prominences circumferentially around that joint, I go back with the feather rasp and take it all down and smooth it.
Yeah, yep, yeah. And yeah, I've used it for lapoplasties. I've used it on adductoplasties. Yeah, pretty much anytime I can use it, I'll use it.
Yep. So at this point, we dissected, we released, we did cup and comb, took down the cartilage, we temporary fixated, and then permanently aligned, or temporary fixated with alignment of the first MTP. Now we get into the Speed MTP system. So this is the standard guide. As we said earlier, it comes in a standard and a large. We have our temporary fixation in, and then this goes over top. And as noted, the screws, the bicortical off-axis locking screws, could be either medial or lateral. Probably the majority of the time, it's most commonly put medial, but it easily could be put lateral, different reasons for that. But Jude, walk us through aligning this. You know, what are we aligning this guide to? What are you looking at here?
So when we put the guide on, there's a central window, and it has two little points in the central part of the window. And ideally, you want those really centered or as close to centered over the joint as possible. And you want to make sure that your crossing K-wire is within that window. That way, when you're making your drill holes for the plate itself, you're pretty much ensuring that you're not going to run into that K-wire or the lag screw that you put across there as well.
Yeah, perfect. So we have that center kind of spike that tells us the center of the joint. And then we want a view, as you said, to look down all four barrels or gun sights at a time. Correct?
Correct. Yes, exactly.
Yeah. So you're looking at all the way to the right, and you can't see the perfect circles. So that seems to be what you don't want. And then Jude, just talk about we once we have this aligned and we aligned the guide at the epicenter of the MTP, and we have our open barrel sights. Now we put on our SureFire targeting guide and talk about how we measure off of this, so we don't necessarily even need the wire.
There's a couple ways. The second picture here, a lot of times what I'll try to do is, if I can get away with not putting an additional little incision there, I'll try to pull that dorsal skin down, and more often than not, I'm able to pull it down enough where I can slip that drill guide right up close to the bone there, so I can minimize doing a small little stab incision there. But once I get that all set there, I will throw my wire across, and there are measuring notches on the targeting guide for your lag screw, which measure at a 26, a 30, and a 34. Sometimes it's difficult to get the right angle with your x-ray to get an accurate measurement. So sometimes what I'll do is I will actually just, once I can see that wire is firmly across, then what I'll do is I'll just take the whole targeting guide off, and under fluoro, I'll just lightly back it off. And then that's a lot of times how I've been doing my measurements.
And that's great. So one of the interesting points of this is you can measure off this guide, the SureFire, just as Jude is saying. So it's a 1-1 wire that goes through this system, and then you can measure off the wire, or you can just look at this guide, with the open sight. So it just increases efficiency and tries to save a step. So this is the alignment of this. Now, Jude, the $1 million question: do you throw this screw now, or
Yes.
do you throw the plate for? Okay, yeah.
So,
there's kind of two trains of thought. We can get into a discussion on that afterwards. But go ahead, Jude. What were you going to say on this?
No, I was going to say I've been because you're right at this point, and kind of like what you're saying as far as like increasing your efficiency. Well, you already have the wire there. I've already countersunk, and so then naturally the next step is then just to throw the screw across. Then we could take that wire out, and then you could just proceed on with the rest of it, because you have a lag screw now, which is fixation, plus you have the drill guide, which is actually very securely anchored down with those hornet tacks, which are
so these are these. Can you guys see my arrow when I do this on the screen?
Yes.
Okay, good. Yeah, so these are the hornet tacks. They go into the lobes where the off-axis bicortical screws are going. So that's your point, Jude. You have great fixation and stability across that first MTP.
Right. typically, you know, in other systems, there would be using a BB tack, and I just, you know, they don't grab really great. There's a short little threaded part on them, and I just have never been fully happy with those. But these Hornet tacks are awesome. They do a really good
these
job.
are threaded. Yeah, to your point. Yeah, great discussion, and we'll show this. So at that point, you have your interfrag screw in. You can see there's still a temporary fixation, so you have 2 points of fixation, and then the Hornet tacks will come off. And what we're going to do is now load the Speed MTP into the impactor. So this is no different than speed plates. And so you have the pre-hold or the pre-drilled barrels. Those were the gun sight views that we looked down. We're going to drill those and then talk about implantation of this and next steps, Jude.
So then, you know, what you'll do is you'll take your fingers and kind of put them underneath the metatarsal head, and then put your thumb through the central part of that the plate holder there. It's like a thumb grip there, and that'll really help you. You can even just squeeze it down with your thumb and put it that way, or just use some light taps with a mallet to firmly seat it.
Yep. Okay, so once that's seated down, now these are the guides for the off-axis bicortical screws, and we're going to take a drill and drill these, and then these are our fast pitch bicortical locking screws that lock into the plate. Kind of has this scoop, so it guides the driver down into that area, so you don't cam out of that screw or cross thread it. You know, what's your typical sizes with this? You know, we measure right off the drill guide. We have a 12 to a 20. What are you seeing typically in the first typically in the proximal phalanx?
Proximal phalanx has been more often than not a 14, and you know, in the metatarsal head, it's typically measuring at an 18.
Yeah, well, I 100% agree. So once those are in, now you have your stability. And you have your interfrag screw, you have the locking plate, all 4 tines are engaged, and then the bicortical locking screws. Once you take this inserter off, this allows the posts to go from, you know, parallel or perpendicular to the bone to a divergent position. And that's how we are getting the continuous compression with this. Some of the points just to talk about is pre-bending of the plates, and that potentially, you know, sets up for a non-union. The most common is probably a 5 degree if you don't set it at neutral, and now this plate does come in a 5 degree bend. Jude, what is your thoughts on this? You know, we set the alignment, hold the alignment, you know, or you use a 5 degree dorsiflex bend in a plate. You know, what's your thoughts on this?
Right now, I believe I've only used these 0 degrees, but the 5 degree is definitely something. You know, if someone has you know, like a cavus deformity, and they need that toe a little bit you know, dorsiflex, like the 5 degree would be a good option for that. But yeah, I don't think I've used the 5 degree as of yet, so unfortunately I can't really comment too much on that.
Yeah. And then the interfrag screw, do you throw the interfrag screw every time?
Yes.
We have surgeons across the country. We have hundreds and hundreds of these implanted at this point, and we have a subset. You know, I don't know statistically, but anecdotally, it's probably 80% throw the interfrag screw, 20 don't. Same outcome. From a company and a construct standpoint, the idea of the interfrag screw serves 2 purposes. Anytime you have a dorsal plate on a hinge in the sagittal plane, no matter how good the plate is or isn't, you'll always get some plantar gapping. So that interfrag screw serves as 2 purposes. The most important, it serves almost like rebar, where it's preventing that plantar gapping. And so that's important. The other thing, because we're putting that interfrag screw before we're using the dynamic compression of the plate, it kind of gets the micro motion or the micro space out of that joint. So the first MTP is manually reduced, temporary fixated. We put our guide over top. We do the SureFire we throw the interfrag screw. Now that joint is compressed. Then when we energize the plate over top of it, that's kind of giving concomitant compression and stability through that area. So it's been very good. You know, the only thing that of caution is some of the literature on pre-contoured plates kind of drive malunion, and we spoke about that earlier. So just to go into a couple cases, this is actually the first case with this ever performed, standard first MTP arthritis. This shows that technique of throwing intermedullary wire. This allows complete control on the transverse and sagittal plane. And because there's only one wire, the frontal plane is simply just rotating the hallux, and you rotate it around it. And then you see, once you have this alignment, I put my guide on appropriately, and then I throw a interfrag screw from the SureFire, and then 2 crossing screws. So this is my wire for the interfrag screw, and I throw a secondary wire, take the intermedullary out. I can see down all 4 barrels, so my drill isn't going to hit. And then from there, this is the guide that's on with the Hornet tacks, and you can see the alignment. Throw the 3.5 cancellous headless screw, and then you're ready for the implantation. This is that thumb holder that Jude had said. So once this is energized onto the impactor, you're going to put the plate into those barrels. These are the guides for the off-axis screw. These are drilled. The screws are filled and locked into the plate. And then once this is taken off, you have your energizing. So you can kind of see low profile, a smooth fit to this area. And this is the case 7 weeks out. So Jude, just talk about this. You know, we don't profess that the biology and physiology of the body accelerates and it heals faster per se. But, you know, with these speed plates, and especially with Speed MTP with the off-axis screws, this is 7-week post-op. And, you know, you can argue this looks like it's 4 or 6 months out. You know, what are you seeing clinically and radiographically?
Yeah, no, absolutely. I think first and foremost, it all starts with with a proper preparation of the fusion site. So as long as you're doing that, and I don't know what your feelings are, but I bone graft every single one of them. So as long as you have proper, fusion preparation, and with this construct, they've been healing incredibly fast, and I've been very impressed with some of the fusion rates that I've been seeing as well.
Yeah, 100%. So Jude, this is your case, a kind of a revision. You want to walk through this?
Yeah, a patient came in. He had previously had a Celastic implant put in, and his biggest complaint was he had a lot of pain sub 2. And my thoughts were like, well, I think he's got a pretty unstable joint. And I told him I felt that the best option for him was to take that implant out and convert it to a fusion. So what we did was take the implant out, reamed. So when you take the implant out in this case, there was more or less kind of flat areas there. So I did a kind of like a high-speed burr, like up into the medullary canal to make sure it was all nice and cleaned out. I bone grafted both ends of it, but then I also took the cup and cone reamer and just kind of touched the base of the proximal phalanx and the head of the first metatarsal, because Treece now offers bone blocks, and the bone blocks that we used was already pre-contoured. So just lightly touching both ends of that gave it a little bit of that rounded shape to it, which allowed that bone graft to sit in there very nicely. And
yeah, what a great point. So between the fast grafter with autograft and now the bone blocks, with the allograft specifically for this, there's a cup and cone allograft for first MTP, TMT, Evans wedges. You kind of have the whole armamentarium, at your disposal.
Yeah, and this was a case where the targeting system for throwing that lag screw was perfect because of the bone graft was in there. We had toyed around with putting a large, but it just just didn't want to fit. So we ended up just going with the standard. And I just saw this patient maybe a couple of weeks ago. I think he's 3 months out, and he couldn't be happier.
Yeah. Awesome.
To
So
both of you,
yeah.
quickly, sorry, going back to the inner frag, you just mentioned it, Dr. Violante, and discussion point. Question came in from a surgeon. Do you think that the lag screw takes up fusion space? So thoughts on that?
No.
That's a great, yeah. So it's a great point.
Sorry.
You know, the idea is if you're crossing the joint, you know, by definition, you're taking some of the real estate for fusion, and biplanar plating really changed the process on that because there's no interfrag screw. So you have good bone-to-bone apposition. Because this is a 3-5 screw, headed screw through this, haven't seen any detriment with taking away that small area of potential bone bridging across this. But I think the benefit of the stability, specifically in potential avoidance of any plantar gapping with immediate protected weight bearing, and then we try to get people in a shoe by no later than 6 weeks. I think that matters for the stability.
Yeah, you know, it's interesting that question. I honestly, until right now, I've never actually thought about that. I totally understand the thought process there, but yeah, I agree. I don't think it takes away from the fusion, a potential fusion area.
Yeah, just not enough. So what's your experience, you know, per the literature, if you have a bunion with a concomitant arthritis, yeah, per the literature, it's anywhere from 3 upwards of 6 to 8 degrees of IM correction. You know, what has been your experience? Do you have a threshold? How do you kind of determine this preoperatively if you're going to need just a first MTP alone or some proximal procedure with it?
Well, a lot of times I'll consent them for both a Lapiplasty with a first MTP fusion. But I do believe, you know, preoperatively, you got to get a really good look at the first TMT joint, and if it doesn't have an atavistic cuneiform, and it's sort of like in this case that we're looking at right now, that looks like what I would consider to be a pretty normal TMT joint. When you straighten up, do the sesamoid release and straighten up that, so that metatarsal will kick in. But I tell the patients, I say, listen, there are times where I'll start with the fusion, and if once I get it all, you know, pinned and ready for plating, if that IM is not closing down the way I want it to, then what I'll do is I will take down my temporary fixation of the MTP, then I'll go and do my Lapiplasty and then go distally and then finish the fusion there.
Yeah, so double arthrodesis, and we'll talk about that. It's interesting because it's really challenging. You know, pre-op, I try to look at the flexibility of the first ray. So I'll take my thumb and push the first metatarsal head laterally at the same time concomitantly pulling the hallux out of a valgus position into a more rectus. And if I find that, you know, somewhat flexible pre-op, a lot of times you can get away with isolated MTP. That's why the great release with circumferential release of the joint and potential fibular sesamoid excision are so important, because that frees that up and gives you that mobility. If I feel like you can't do that preoperatively, sometimes it's challenging to get that alone. So in those cases,
sorry, quickly question to this exact topic. Question came in on what about putting on the positioner to reduce the IM? Yeah. Do you ever do that? Do you think that would help?
Yeah. So 100%. So our first published paper on triplane correction of the first MTP was using the positioner. So we would use the internal positioner. You can easily use the external positioner to do it as well. And you will reduce that intermetatarsal angle with the positioner, temporary fixate it, just like we say, and then take that off and then proceed with the Speed MTP. Have you ever used that, Jude, the positioner?
Yeah, I've used it. I've used it definitely a couple of times. I mean, all the points that we're making are really good points. Like you said, preoperatively, trying to manually reduce that. I'm not shy about doing a double if I really think I need to. Sometimes I get even if I do get a good release, I always get a little worried about like a spring back. As far as once you pin it and then you take the positioner off. Sometimes that's just always in the back of my mind. I haven't had to use it enough to know if that happens, but it's something that always kind of lurks in the back of my mind.
Yeah, what a great point, and you're absolutely right. Once you put that positioner on, if it does spring back, then you're kind of obligated to go proximal. So, what we're talking about is double arthrodesis. We published on this. Knee jerk, it seems taboo, like you're going to have a stiff medial column. I find this is one of the most gratifying procedures I do. You want to talk about whether the indications for a double and when you use this in your practice, Jude?
Well, first of all, I couldn't agree more. It's extremely gratifying, especially when you see someone that has a large arthritic bunion, and in post-operatively, it's as straight as an arrow. It's very, very good to see that. It's very an enjoyable procedure. I love doing them. I do a fair amount of doubles. I don't know if I just get that type of clientele seems to come in, but I would say. I don't know how many people are doing doubles across the country, but I would say that I'm as I mentioned before, I'm not too shy about doing a double, and it's just some of those for me personally are more intraoperative decisions. That's why I like to consent them for both of them, even if we get a full release and I'm not getting it to straighten up with when you straighten the hallux up, then we already have the ability to go ahead and add the Lapiplasty to it. So that's been my standard of practice, is to just consent them for both. And that way I have the freedom to do what I need to do when I'm in there.
Yeah, 100%. So what we're talking about, we say double, it's a concomitant medial column, TMT and MTP fusion, but the double really is reserved for that stiff joint. You see that gapping in the X-ray revision cases, a stiff medial column. You see the gapping, that's what we're talking about. That first MTP is fused, you could say, in an acceptable position, but look at the gap between the first and second, and really it's lack of control at this and our TMT, so that's kind of what we're looking at. The paper that we published on this is, real world functional outcomes of double fusion, and the perception of a stiff foot or medial column that you can't pulse is really unfounded. The first MTP drives the entire medial column in first ray. We know that the literature is replete with functional outcome of first MTP fusion. To add the joint proximal to TMT, which arguably has maybe 2 to 4 millimeters of motion, that equates maybe to 3-4 degrees of motion, really changes nothing in my mind, nor in my patients that I see clinical with the outcome of this. Jude, anything to add in that regard?
No, I think it's spot on. Everything that you just said there is, I couldn't have said it any better.
So Jude talked about this. So the double's not enough. So you have a patient that has a bunion, has arthritis, and metatarsal adductus. What would you do here?
Well, I mean, this is a clear, we call it a quad case. We're doing your Lapiplasty, adductoplasty, and first MTP fusion. And I'll tell you what, this patient just did so well with this. He had really bad chronic gout, and I remember this case because I had the hardest time trying to even identify and isolate the second and third TMT joints. But once we're able to identify it, you make your cuts, straighten those up. It's just such a gratifying procedure. The patient's just ever grateful that their foot is not in pain anymore. They can wear shoes comfortably again. They can function again. And but yeah, no, this is a really good case for a quad. The correction you can get with these procedures is just incredible.
Yeah, and I mean, we're talking about a foot width decrease. We published the data on this with adductoplasty and lapiplasty, anywhere from 1 to 1.5 centimeter. And you see that sometimes you just have that bony block. My same comment persists. This looks like a stiff foot. It is not. They function the exact same as they would with an isolated first MTP. So when you add the one TMT or 3 TMTs, in this case, I've seen no difference from a functional standpoint, but your alignment is clear. So Jude, this is our last case here. Talk about this. This looks like an adductoplasty with severe arthritis, first MTP, obviously how it's valgus. What'd you do here?
Yeah, so I mean, this would be another great case for a quad where you would do the adductoplasty, lapiplasty, first MTP. But sometimes you have to look at the whole picture here. You have to look at more than just the X-rays. Well, in this patient's case, 61-year-old female, she does have a history of cerebral palsy, and she has deafness and hypertension are her main diagnoses. And when you do a quad, it's a little bit more of a recovery for the patients. I typically have been keeping them casted and non-weight bearing for upwards of 3 weeks. And with a double, I have felt that I don't have to do that aggressive of a post-operative protocol for these patients. So right off the bat, I thought, you know what, I just don't know if she's going to be able to handle all of this. And I thought she's got enough of a bunion deformity that I felt confident enough that I could certainly straighten that up and do a double there and get enough correction where she can have that large bump removed and do quite well with that. And I definitely struggled with my decision here, but I finally decided that a double was appropriate for her. And I just saw her last week, and she's doing fantastic.
Yeah, and that's part of the algorithm. In our initial slide, when we look at our algorithm, if you have arthritis at the isolated first MTP, or if you have arthritis with a bunion, you have either the single MTP fusion or a double. If you have adductoplasty with arthritis, you either have the single MTP, double, or quad. So I think it's phenomenal. The only thing you and I differ on is post-op. My post-op protocol for these are all exactly the same, whether it's an isolated lapiplasty, double isolated MTP, adductoplasty, quad. They are protected, weight bearing. I put them in a splint just for the post-op bleeding and swelling. So they're weight bearing with crutches for balance, 10 days with a splint. And then after 10 days, sutures out in a boot. They're full weight bearing to tolerance in the boot. And all these, whether it be a double, lapiplasty, adducto, whatever it is, I try to get them in a shoe at the 6-week mark. The double, or the adductoplasty, I should say, in the quad, sometimes you're pushing 7 weeks to get them in the shoe just because of the swelling. But the plate and the stability of this.
It's the swelling that seems to be the biggest prohibiting factor for patients getting into shoes. And that's what we all definitely differ a little bit, right?
Yeah, 100%. Yeah, 100%. So that protected weight bearing really seems to helps with pain, helps with swelling, helps with function. And so, that's just one of the things that we want to put out there because we've published on that. And then lastly, we have about 100 patients and we are doing a retrospective study. This will be presented for the first time at ACFAS in Vegas, coming up at the end of February. And we have our 6-month data. We are currently in the process of collecting 12-month data. And this is for the Speed MTP plate. And, to date, just as expected, the outcome has been phenomenal. This has been something that's really been a game changer. So any questions remaining?
Yeah, a couple. There's actually some good comments coming in going back to the hallux interphalangeus. Surgeon says that he has done osteotomies of the proximal phalanx and then incorporate that into the plate fixation. Thoughts on being able to incorporate that into the Speed MTP plate? Maybe it needs the larger version. Currently, he's using our traditional plating system, but has not tried it yet with the seed plate to see if the tines could capture both sides of that osteotomy.
Yeah, so Jude kind of talked about this earlier. Really, it comes down to stabilization of that bone segments. So in essence, you're creating two bone segments that need stabilized, the MTP and then the osteotomy. And I don't have any experience spanning any plate that could do that. You would look at, if I was doing a case like that, I would look at our revision plates, the S3R or S3 plates, which are the revision. They're a little longer, and they would be able to span potentially a double fusion site. So Jude, any comments on that?
Yeah, I mean, I get what they're trying to state. I just feel like that's going to be a difficult thing to try to pull off, when trying to do an osteotomy, keep the ostomy closed down, and then throw the drill guide and so on and so forth on top of it. I feel like it could be a little difficult to try to pull that all off.
And again, if you can span it and get the bone segment stabilized, good on you.
Yeah.
What's
Yeah,
the other question, Lauren?
Next question, for the revision that you did, Dr. Violante, with the tholastic implant, any concern about collapsing the larger canal that was made by that implant?
No. So I mean, we packed it full of bone graft, and yeah, it certainly was a concern. With him, I was a little bit, I believe I kept him non-weight bearing for a couple of weeks, just because of, what we were dealing with him. We did use, he had pretty solid bone too, if I remember correctly. So I was pretty impressed with his, the cortical shell that he had there. So that definitely was a thought, but in this case, it didn't prove to be anything detrimental to the case.
Yeah, I have two things to say on that. With the advent of this off-axis bicortical locking screws, even osteoporotic bone, this plate is solid. And so I have no hesitation using this in revision or osteoporotic bone. That's number one. Number two, unlike the staple system, and when you put in the tines and you energize it, they don't go to a zero angle. Like a nitinol staple will actually touch. And this doesn't do that. This takes it from a parallelity of the tine into a divergent that gives you a continuous compression, but that divergent does not go to a zero angle, meaning the tines don't touch. So I'm in Pittsburgh, Jude's in Buffalo. We have snow on the ground. I liken it to shoveling snow. And if you were shoveling with the snow and you have a driveway, you can only get so far until that snow is so heavy that you have to kick that snow off the shovel and then start again. In my mind, that's what's happening with these tines in the bone. It's gathering bone as it's compressing, and then there's an end point. So it's squeezing all that bone together. So with this specific plate, the Speed MTP with the off-axis screws, I have not seen an issue with osteoporotic bone or revision where there would be some sort of bony deficits. In addition to you packing it, like you said, Jude, I haven't seen an issue. This has been super stable.
Yeah, and to the points that you just said there, with those nitinol staples, I've had them break right at that at that angle where the tines meet the main part of the staple. And the cool thing about the Speed MTP is that's not where the energy is. It's in the middle of the plate there.
Great points.
All right, so last question. You kind of hit on this initially in your post-op protocol. Thoughts on changing it if it's a revision of a non-union? Would you keep them off longer in that particular scenario?
So I will tell you my thing, and then Jude could weigh in. One of the things that we've tried to do with the Lapiplasty system and the family of procedures is decrease the morbidity of surgery, and the deconditioning of the patient is really something that's real. So a lot of times, whether we're non-weight bearing or cast immobilization, this and that, none of that is wrong. What I would say is I would try in my practice to limit that no more than 2 weeks, to Jude's point, 3 weeks at the most. That's all acceptable. And a lot of times, if they have a delayed or non-union and they're getting a revision, you can arguably say that's when you want them weight bearing even more, because they already had a non-union. So you want that stimulation. So that's just kind of how I see it. But to have a period of protected or even non-weight bearing is appropriate. I just think the days of 6 to 8 weeks are way too antiquated with these fixation systems.
Yeah, I 100% agree with everything you just said there. I just don't think that there's ever a need for someone to be 6 weeks non-weight bearing. It's very antiquated, and I very much agree with that. Sometimes maybe you just need to dive into, well, why did they get a non-union in the first place? Was it poor preparation of the joint? Was it, things of that nature? But I not sure I can say anything.
We even talk about, vitamin D optimization. We're in a non-sunny area. We talk about protein intake, 100 grams of protein a day. So all of those things matter. But sometimes you can be overcautious with surgery with protected and or non-weight bearing. And I think that has been a detriment. I have orthopedic colleagues that don't use casts at all, even ankle fractures. And that immediate mobility, whether it be an open kinetic chain range of mobility, the washing of the area, all those things matter. And so I think that we have a lot of published data on isolated Lapiplasty, double arthrodesis, isolated MTP, adductoplasty. Anything we haven't published on is the quad, but it functions the exact same way. And
Correct.
They are all immediate protected weight bearing, usually in a shoe around 6 to 8 weeks.
Yep. Yeah, very good.
Fantastic. Thank you. That is it so far. Both of you, thank you so much. This was absolutely fantastic. Cannot appreciate or show our appreciation enough for all of your experience. Thank you to all of our attendees who made comments, asked questions. We love the interactivity, so very much appreciate it. If you think of something you're hanging up after the fact, you have questions about Speed MTP or any of the Treece products, please reach out to your local sales representative. You can always reach out to the medical education department, the product management department. We are happy to assist you. We do a ton of peer-to-peers as well. So we love doing these webinars, but if you're looking for something a little more one-on-one, discuss a case, plan for a case, we do these peer-to-peers almost daily, right, Dr. DeCarbo, that you guys are involved in those?
Yeah, 100%. One of the beauties of the company at Treece is, we're not out there selling products per se. We're professing a philosophy of a triplane correction with immediate protected weight bearing and circumferential stability. And then the support with that is incredible. So to Lauren's point, you can talk to engineers, you can talk to design surgeons, whatever, to kind of bounce cases and bounce ideas off each other. So we're 100% committed to the success of the patient, and that's your success as a surgeon. So yeah, please reach out with any questions or issues. We'll help best we can.
Absolutely. We have a number of medical education events throughout the year coming up. So if you're interested in attending any of those, getting hands-on with any of these products, especially Speed MTP, which we're here to talk about, again, please reach out to your local representative or to the company directly. Thank you for being with us this chilly evening. And Dr. DeCarbo, Dr. Violante, thank you so much. Hope that you have a great evening.
Yeah, thank you. I appreciate the opportunity.
Thanks, guys. Nice job.
Have a great night. Bye-bye.
All right. Bye-bye.